Welcome, welcome, everybody. We'll just give it a second as everybody is added into the webinar. Apologies for the slight delay in our start. So appreciative that you can be here with us today for our final pre-summit webinar, Jurisdictional Roles in Canadian Healthcare, including specific to First Nations, Inuit, and Métis. And my name is Leah Stevenson. I'm based in Toronto, which is the traditional territory of many nations, including the Mississaugas of the Credit, the Anishinaabeg, the Chippewa, the Haudenosaunee, and the Wendat peoples. And Toronto is now home to many diverse First Nations, Inuit, and Métis peoples from across Turtle Island and indeed from across the globe. And so I am just very grateful for the ability to live, work, and play on this territory. It takes many incredible people and organizations to pull off an event like this webinar and the summit that is coming starting next Monday. And so we really want to thank the two patient partner organizations that co-host and make this webinar and the summit possible, and that's Save Your Skin Foundation and the Canadian Psoriasis Network. And we really also want to thank our sponsors, without whom none of this would be possible. So Janssen, Merck, Pfizer, Roche, Sanofi, Amgen, Bristol Myers Squibb, AstraZeneca, and Novartis. Thank you so much. None of this would be possible without you. And Innovative Medicines Canada, a special thanks for your support of our working groups that help patient groups continue the efforts on common issues and opportunities in between these events. So we're constantly trying to improve healthcare together based on what we're learning at webinars like this and at the summit. Thank you to the Summit Organizing Committee members, Sharon, Louise, Antonella, Chantel, Kathy, Taylor, Sylvia, and I'll pat myself on the back. It's a lot of effort throughout the year, and it's always really thrilling to see it all come together. Thanks to all the members of the three working groups and the chair people that continue the efforts in between events. Special thanks to our French interpreter today, Sana. And also thanks to our technical support, Lance Lee. So a little bit of housekeeping. Throughout the webinar, you will be muted and the videos will be off. We are, because we are recording, and so don't want there to be interruptions of the recording. The session is being recorded in English and French, and we share all of the content through Save Your Skin Foundation's YouTube channel. So if you've missed anything and want to catch up on what you missed, please check that out. And you can also check out content from previous webinars and summits. To access the French interpretation, just click on the world icon at the bottom of your screen, click Mute Original Audio, and then select French. If you have a question, you can use the chat function at the bottom of the screen. So type your question in there and press enter. And same if you're having technical difficulties, contact Lance Lee through the chat function. Now, I'm pleased, I'd like to encourage everyone to please share the ideas that are inspiring you through your social media accounts. And you can use one of these three hashtags to let people know that you're part of this conversation online. That's hashtag Patients Redefining Healthcare, Patients Summit 2023, or Patients Redefining HC 2023. Now I am pleased to introduce our two co-presenters for today. Louise Binder is a lawyer, health policy advocate, and health policy consultant with Save Your Skin Foundation. And Carolyn Roberts is Ottawa Hospital's first Indigenous nurse navigator for the Indigenous Cancer Program. Her 25-year nursing career has been predominantly set in Northern Quebec and Nunavut. Over to you, Louise.
Thanks very much. My first slide was a cartoon of a snail, and it says, "Let's go to the other end of the leaf." And the other snail says, "Road trip." And the quote is, "If you don't know where you're going, any road will get you there. So some symbols that these might represent, snails go very slowly. You can decide after this webinar whether what you hear about our jurisdictions and how they manage healthcare fits that definition. And also, you do really have to have a roadmap to get anywhere. And hopefully we'll let you see the roadmap. And again, you can decide if it's a detour, we're getting a lot of detours, or if we're getting a straight road from where we need to be once a drug is developed to where we want it to be, which is to patients who need it. So that's that story. So we're going to do it as usual because we have a federation. We have the federal government that has some responsibilities over healthcare, including drug access. And we then have the provinces that have some responsibility as well. So I'm going to talk to you a little bit about the federal roles first. And Carolyn's going to jump in and talk about the federal roles from the Indigenous perspective as well. I'm so pleased that she was able to join us to help us understand that aspect as well of healthcare. And then we'll move to the provinces. So there's kind of three layers. You've got the law and public policy, and then you have implementation of those laws and public policies, and then you have the monitoring and evaluation of both your laws and your implementation. So I think of it that way. It makes it easier for me to follow what's going on. So let's take a look then at who does what in the public sphere in healthcare. This is I call it a complex pathway to patient access. And I'm not going to describe each of these. And I'll say just a couple of things. Each year, there are new boxes that get added, and I've yet to see one box disappear. You can decide what that means. So last year, we didn't have the Canadian Drug Agency, but we now do. And we've added in, although they were there before, just not on our screen, the Public Health Agency and NACI, which reports to them and is responsible for vaccines. And of course, we know that they have become more and more to the forefront. And indeed, there may be cancer vaccines coming along too. The two orange boxes are specific to Indigenous healthcare. So I just wanted to make that clear. So that's what we've got. And now let's talk about what they are. So it takes somewhere, I've been told, between 7 and 10 years to actually get a drug to the point of development. So that's a long time. And then, of course, it has to, if you want to bring it into Canada, you have to get it through the first set of boxes, which is Health Canada and the Patented Medicine Prices Review Board. So those are the two federal agencies that we're going to talk about on the next couple of pages. So what do they do? What are their laws, and what are their implementation roles? So if we should go to the next slide, you'll see that the federal government, there is still a strong misunderstanding about the role of the federal government in providing healthcare. Under the Canada Health Act, they promise us doctors, and they promise us hospitals, free, with universally and with no charge. And of course, we all know that there's a lot of rough around those edges, but at least that's the commitment. Also, they approve clinical trials and treatments and medical devices and many other companion diagnostics and many other things that we need in order to get drugs out of development and approved for sale in Canada. They also, through Vanessa's law, have a role of post-surveillance of drugs and to ensure that the drugs that are on the market are safe and effective. They also, through the Patented Medicine Prices Review Board, must ensure that the price that a seller wishes to sell a drug for in Canada is not, quote, excessive. And the way they choose that is through looking at the median price for now 11 countries, and it cannot be higher than that. So they also, of course, manage health policy, as I mentioned earlier, and of course, the Public Health Agency and NACI became very prominent during the pandemic, and I'm sure they're planning for the next one, unfortunately, and they manage insurance. So those are the federal laws that we need to be concerned about once we've developed a drug and we want to get it onto the public, into the public sphere in Canada. So if we go to the next slide, now I turn it over to Carolyn to talk about law and policy from the Indigenous perspective.
Hello, everyone. Thank you, Louise and Leah, for including me. I also like to acknowledge I work here in Ottawa, so I like to acknowledge the Algonquin traditional and unceded land here. And I also like to acknowledge where I'm from, of St. Paul's River, Quebec. The traditional peoples are of Inuit and Inuit descent. I do not self-identify as Indigenous. My title may be misleading. I do not self-identify as Indigenous. So NIHB, I've been a nurse working within the NIHB spheres since 2009, and I continue to learn every day, and I'm continued to be baffled by its complexity.
Carolyn, can you tell us what NIHB stands for those of us who don't do this every day?
Yeah, sorry, I apologize. So NIHB is non-insured health benefits, and that is not, it is specifically for status First Nation and land claim Inuit. So there's this broad misconception out there that if you self-identify as Indigenous, you are automatically under non-insured health benefits. That is not true. For Métis people specifically, as far as I'm aware, the only Métis people who fall under NIHB, non-insured health benefits, is in the Northwest Territories. The only Métis people of Canada that fall under NIHB is the Northwest Territories, status First Nation, and land claim Inuit.
So that's quite a different set of rules, if you like, or policies and programs than we saw with non-Indigenous, non-status Indigenous people and some Métis. Is that, yeah, okay. They have their own kind of process.
It's very complex. We do a presentation here at the Ottawa Hospital called First Nation Inuit Métis 101, and it's really debunking the myths and the misconceptions of all Indigenous people across Canada. But I can elaborate more into that.
Yes, I'm sure you're going to come to that. So if we go to the next role of the federal government, so they make the laws, they make the policies, and the laws and policies that they make, they then implement. I'll speak to 2 and 3, and then I'll turn it back to Carolyn to speak to 1. So one of the things that the federal government does do is create some specific health strategies and put some funding behind those strategies. They do have an HIV strategy. They do have a mental health strategy at the federal level. They do have a cancer strategy at the federal level. And a new addition to our list this year is that there is now a pan-Canadian health data strategy for which funding has been provided to CIHI and to Canada Infoway. So we'll talk more about that in a bit, but that's new. And they, of course, also can provide guidelines in selected areas, but those are not they're not people don't have to follow them, but they're discretionary. So talk to us about number 1, Carolyn.
Okay, so for the non-insured drug benefit, it is very it's federal. the money comes federally, and then it's divided into the provinces and into the regions, and is not standard across the board. So the coverage of a First Nation person in Quebec will not be the same coverage as an Inuit person in Nunavik, northern Quebec. And how I'm not an expert in a NIHB, but I can only share a little of how I learned the differences. And so, Louise, is it okay if I share the visual aspect now, or you would prefer?
Why don't we just go through the roles, and then you can get into the complexities, which I know are many. So at the federal role then in implementation, in addition to the ones that we've had in other years, their own employees and federal RCMP, federal penitentiaries, etc., they also have through the Constitution Act, right, Carolyn, that these benefits are provided to the people that they decide are going to be providing it. Okay, so that's how now and now for something completely different. Please take us through some of the complexities that you indicated exist in the implementation of these benefits.
Okay, so it is very specific that, yes, what we see here, prescription drugs, over-the-counter medications, dental vision care, medical supplies, equipment, you know, it sounds very inclusive. It looks great on paper. It's hugely complex and not quite as easy to access. So as I was alluding to earlier, the first encounter where I saw the differences just between a First Nation and Inuit coverage, I worked in a community that it has 4 names. English is Great Whale, French is Poste de la Baleine, Watmagustu in Cree, and Kujarapik in Inuit. So in this community, the clinic is shared by the Inuit and the Cree. And so the entrance of the clinic, you come into a triangle, the point of the triangle. And if you're Cree, you go to one side. If you're Inuit, you go to the other side. And if you're not Indigenous, you can choose which side you would like to obtain healthcare. Most people went to the Cree side. And the reason why, better staffing, better funding, but particularly for NIHB, when I went into the pharmacy is shared, but it's the size of what I would say a boardroom. So this Cree and Inuit pharmacy is a boardroom, but what was designated for the Inuit was the size of a closet. Both are under NIHB. The Cree had dozens of shelves of medication. The Inuit had about 5 shelves, the size of a closet. Yet, so that is because the Cree have their own Cree health board. The Inuit under land claims is under, it's all so very separate. And so just by that visual, you could see it is not divided equally.
So Carolyn, let's just stop there for a minute, because this is astonishing, at least to me, when you first described it to me, and I just want to make sure that our audience really understands what you're telling them. So the benefits overall are provided by the federal government through the NHIB, right? Okay, so and some people get those benefits directly from the federal government, right? Is that correct?
So the funding goes through either the band, it goes through the provinces, then the regions. Yeah. Okay. So it's down 3-tier.
Okay, so the federal government provides the funding for the drugs, and then they give that funding to the provinces.
Yeah.
So in some, let me just make sure I understand. In some cases, the provinces directly provide those drug benefits through their normal drug plans. Is that right?
Yes.
In some cases.
But see, within each province, there's different bands, there's different First Nations peoples, and then there's the Inuit, which is a land claim. It is not distributed equally, is what the point I'm making is, it's that some nations are stronger than others. Like the Cree of Quebec, they're a very strong nation, very strong leadership. They have the benefits of the hydroelectric dam of James Bay. So, like I said, on paper, yes, it's handed down, but who it goes to is not equal amounts. It is not an equalization process.
Okay, that's a first very important point for people to understand. And then you have a list here of different Indigenous bands, and if I'm correct. And let me understand, and our listeners to understand, these bands, this list are bands that actually manage their own NIHB benefits. Is that correct? And they're different. Each one is different. But it's the band that makes the decision in each case how that funding is going to be distributed. Am I getting that right?
Correct. So for a non-Indigenous person, it would be similar to your municipality, your LIN, right? So your band is really your local politician, right? Your local, that's how I best can describe it. It is not an equalization process across the board.
And the decisions are made within these groups by the bands themselves, how they want to distribute it. Is that correct?
Yeah, yes. Yeah.
Okay. Well,
and
that's complicated and not, so it means that there are different drugs available to different bands depending on the decisions that are made at that level. Is that right?
That is correct, but also, so NIHB, the list of what's covered, what's taken away, what's added, changes routinely. So another huge misconception is that everything is covered. That is not true. So a lot of case managers spend a lot of time filing grievances with NIHB, their local NIHB, for medications that were covered, no longer covered, or partially covered. It is not just a free-for-all of coverage at all. And that is also in terms of the mental health counseling. There's limitations. It's very similar to when we have our benefits as employees of whatever organization. There's limits, there's limitations. It's the same with NIHB. But I could
go ahead.
So another thing with NIHB, the mental health, the vision benefits, it is also, you have to find if you're living on reserve, you don't have to pay. But if you're a First Nation or Inuit person living in an urban setting away from your land claim community or your reservation, you have to find a provider that will accept NIHB, because they are few and far between here in Ottawa. And if you do not find a provider, you have to pay upfront and then submit to NIHB for coverage, which can be a lengthy process as well.
So it's coverage for drugs, is it coverage for other things as well that you have to pay in advance? And then
if you're living off reserve or off your land claim community, you have to find the provider, the dentist. Like there's only two dentists here in Ottawa that I know that will accept NIHB, the land claim for Nunavut, right? So it's very complex. you have to do your research. When you live away from your community, you have to do your research. Who accepts NIHB, who doesn't, and then you have to submit for reimbursement, which also can be a lengthy process as well.
And it sounds to me, correct me if I'm wrong, if there's only one dentist who's accepting NIHB forms, you could wait a long time to get service, I would imagine.
You do. You wait a very long time. Yeah. Like I have patients myself I worked with who are into the 6 to 8 months still waiting.
Oh boy.
Yeah.
Okay.
So looks good on paper. It all looks great on paper.
And tell us about Jordan's principle.
So Jordan's principle, it's a very sad case of a little boy who essentially, I can't speak too much about it because it's so emotional, but he essentially, he passed away in hospital without, basically with the federal and provinces arguing over who should pay for his care. And because of Jordan's principle, because of Jordan and the tragic tragic passing for basically being an Indigenous youth, and the governments were arguing over who should pay for his care. So when you started speaking, Louise, when you said universal health care in Canada, I think all healthcare providers cringe because it's not universal. It's not universal. Like here, I work at the Ottawa Hospital. I can't work with the First Nations people of Quebec, of Maniwaki. It's Kitigan Zibi. It's not universal. And so essentially, George's principle is for any youth who needs care, regardless of where in Canada, the family or guardian can access funding through Jordan's principle for the things that NIHB aren't covering. And that's a wide variety. And it's assisted so countless families that I know of for the short time that it's been active. Yes, I really can't articulate. Yeah, I can't articulate it well because being having worked with Indigenous populations for so long, it just strikes too close to home.
But people do need to know about it. So thank you for explaining it to them. You know, we hear it, but we don't really know what it is.
Yeah, and so it essentially, I'll just say it essentially covers what NIHB doesn't cover.
Okay, we can understand that, sort of. Yeah, sort of. If we can figure out who was who and what was what. Okay, so then so we talked a little bit about implementation, and we've talked about the laws that promise us doctors and hospitals, and we've talked about the specific rules and implementation in the Indigenous communities. And now then, of course, they have evaluation principles that they follow to make sure that what they're doing and what they promise is actually being done. And most of us know these, but the ones that have really come to the fore in the last few years are the bilateral agreements that now the federal government is negotiating with the provinces for Canada Health transfers. So that's new, and a few of the provinces have already negotiated those agreements, but many haven't. So it'll be very interesting to see what's negotiated between them. The other thing that's quite new is this great recognition that data counts, and if you don't get counted, you don't count. So we now, through the Canadian Institute for Health Information and through Canada InfoWay, there is a whole system of data management that they're developing and working with the provinces to develop. And of course, now we know much more about public health and infectious disease than we knew before. So if we go to the next slide, just some thinking ahead. And of course, we never know for sure, but thinking ahead, I think there is a commitment to a Pharmacare Act by the Liberal government, so we may well see that. We don't know what it'll cover. As I mentioned, all the other bilateral agreements will have to be resolved, and we'll see what measurable indicators are there. I know there's a separate agreement for Indigenous populations. We have the announcement of a rare disease framework, but what it's going to be, we don't know. It seems that our health technology assessment and management groups are slowly inching into an understanding about the importance of looking at real world evidence, the importance of accepting trials at an earlier phase of trials, with time limit reimbursement agreements. And so slowly we're starting to see some movement there. And as I've mentioned, we now have the Canada Health Data Strategy. I think we're going to see through the Pan-Canadian Pharmaceutical Alliance, which is the negotiating body for all the provinces for drug pricing for the provinces, although the provinces still to make their final decision about whether they want to implement it. I think we're going to see more what they call managed entry agreements, pay for performance, risk sharing agreements, going along with the real world evidence and the time limited reimbursement agreements. And now, please help us and understand what you think is coming for in Indigenous populations.
Is coming, or what?
The changes and issues you think are sort of in the forefront now for these populations.
So, so the good thing that we are seeing with NIHB, and like I said earlier, we're continuing to learn. So, there was this big misconception, even within the Indigenous population, that if you had private coverage, you could not be covered under NIHB, was either or. And that is not true. Now, I only found this out this past year, and I've been working with this population for many years. So your benefits would go through your employer at whatever pharmacy you use. And if that pharmacy works with NIHB, if it's not completely covered, it will then be submitted to NIHB and potentially fully covered or not. Mm-hmm. So that is a good thing.
So that's sort of that's been around for a while, but the change is that it's starting to be publicly understood.
That's right. Yeah, because NIHB is so complex. Like, they have experts that give like day presentations, right? It's a very complex system to understand, and things are constantly changing. They don't have enough employees. We hear that a lot within Indigenous communities, understaffed. They do try their best, from my experience, with the policies that they have in place. But another thing that I would say really needs to change is NIHB, the access is Monday to Friday, 9 to 5. And when crises happen in healthcare, it's not usually Monday to Friday, 9 to 5. So to improve access to emergency funding or whatnot, we need more of a 24-hour call center, like in the community. Again, if you're working in an Indigenous community on a reserve land claim, you do have 24-hour access to healthcare centers where the NIHB is fully covered in those pharmacies. But when you live in urban settings, that's when you really get into the complex issues of not only drugs, but for travel, for example, for transportation. So here in Ottawa, folks from Northern Ontario would have to come here for stem cell. I'm frequently bringing patients to airports, groceries, just because that NIHB funding hasn't come through. And it's
Okay.
always,
So
you know,
hopefully you're going to see some change so that it becomes not just a 9 to 5 exercise, and people will really have ongoing access.
you need that
Okay.
emergency access to funding.
Emergent, yeah, that's it.
Yeah.
Okay, so now to our patchwork quilt. We talk about a patchwork quilt, and it is because we have the federal government doing some things, and then we have each province doing something else. And the main thing for this group on this call is that it is the provincial governments that actually make the decision about public reimbursement of drugs. They decide which drugs are in the public interest for taxpayers to pay. And each province is different, and each province makes its own decisions. So we do not have equal access in every province. Not everything, the same things are covered in every province. And we don't have equitable access either, which is rarely understood, because sometimes you have theoretical access. That is, there are some programs that you can apply to with the government, but they require deductibles or co-pays that people can't afford. So although theoretically we have these programs, people really don't get into them, and so that's a problem. And you tell us a little bit about the laws and policies at the provincial level that are particular for Indigenous populations.
So do you want me to discuss number
Yeah,
3?
3 and 4 are your jurisdiction.
So number 3, when developing for non-status First Nation Métis people who self-identify, that's a very contentious issue within the Indigenous community, within the status and land claim, because there is this poor understanding of who are the Métis people, right? And a kind of a misconception, I would say, is that some folks will identify as my great grandmother way back, she was First Nations, so that makes me Métis. That is not correct. There's a lot of advocacy work going on right now about who is non-status First Nation people, who can self-identify. We're seeing a lot in the news with Buffy St. Marie, and it's very emotional, it's very contentious. But then when you are self-identifying and getting access not only to NIHB, but also self-identifying and getting employment opportunities, that's where we need more regulation. I hate to say that, but we need to have who can self-identify. What does that mean? There's a lot of organizations that exist that are not recognized by First Nations community or Inuit community.
So am I right then that the impact in health on that is that the people who are not accepted, if that's the proper word to use, are not identified in those categories, do not get the same health benefits that people who are identified. So that's I guess that's still under discussion as to how that's going to be. That's interesting. And what about the fourth point that you have there?
I kind of said that we need more round the clock access. We need that voice at the end of the phone. Again, when you're in your community land claim, it's okay. But when you fall out of that, then it gets really complex. And we see folks going without transportation, not making it to appointments, not having, they're having a mental health crisis, not having food, because they paid for medications out of pocket. So we see sometimes the cycle of poverty just worsen, even though they are entitled to NIHB benefits and waiting for reimbursement. again,
Okay.
like we have a lengthy presentation and all of that. It's very difficult to summarize NIHB without getting into the inequities within our First Nation, Inuit, and Métis people.
Well, at least let's get people's toes in the water who may not have heard anything about it yet, and then maybe we'll move to those more complicated discussions. So if we go to the next slide, in the implementation stage, so they make policy decisions about drugs and a lot of these things, and they also implement. They are the implementers, and it's public drug coverage, it's pharmacies, primary care, mental health. These are the implementation pieces that the provinces take on. They have cancer agencies, they do data collection, health data collection, they manage clinical trials, and they implement public health measures with municipalities' public health roles. And number 7, over to you, Carolyn.
Yeah, so not covered by the federal government.
So the provinces take that over.
And
okay.
Yeah, so with there are programs in what I would say our community partners, when you're living off reserve, off land claim, like here in Ottawa, we have multiple like Wabano, Akausafic, that help. There are nonprofit organizations that service the local Indigenous community, the local First Nation, Inuit, and Métis.
Okay.
But within those nonprofits, not everything that it's covered. Like, people just assume these organizations will have this wide range of services, which they do, but it does not completely address the poverty, the mental health struggles. Much more needs to be done. Like, it's just little pockets of money, and we see that throughout all underserved populations in Canada. We see small pockets of money that doesn't really address the need. And
yeah, I think at our summit, we're going to spend 3 days talking about social determinants of health and poverty and all of these that impact. And as you know, the second day is specific to Indigenous health. So we'll be talking a lot more about this problem and its implications for health. So thank you for setting that up for us. Next slide is monitoring. So we have treasury boards, and we have quality control boards and health advisory boards that are there to monitor and evaluate what the province is doing. Next slide. Okay, theoretically, the federal government looks after also private insurers, and I'm only mentioning them for one reason, and that is that people believe that when they or their employers or their unions, however they get this, that they get private insurance. The idea is whoever's paying for it is getting more than what the public plans are reimbursing. And that has been true for a long time. But now what we're starting to see is a shift where the private insurers are saying, we're just going to cover what the public insurers cover, or we're going to wait to see what the public insurers decide they're going to cover and make our own decisions. This is quite a shift, and certainly, in our opinion, not in the right direction. So the next slide. So there we go. At the beginning, you saw it in kind of that waterfall, you could call it. And this is another way of showing the complications that we have in getting a drug from discovery and ready to be in clinical trials. They have to go through Health Canada review at the federal level. They have to go through Patent Medicine Prices Review Board at the federal level. Then the provinces work together through their health technology assessment organizations to decide, to make a recommendation about reimbursement for the provinces. Then goes down to the Pan-Canadian Pharmaceutical Alliance to negotiate a price with the companies. And then this is really important, each province still has a final say in whatever all of those agencies have said. Each province still has a final decision in what it's going to list and what it's not going to list on its public reimbursement plan. So that's a very important thing. So that decision making, they can decide to put criteria on reimbursement. They can decide what the price is going to be, utilization. They have the final decision. And the exception is in your area. So describe the exception for us.
So with non-insured health benefit, like I said earlier, drugs are added, removed on a continuum of basis, right? So it's really folks who access NIHB regularly need to be constantly updating and researching. And that's it. NIHB is great for the regular over-the-counter, but it's when we get into the complex, like cancer, complex medical issues, where we see the inequities. So
okay, so that's so like the provinces, there are lots of inequities.
Louise, you're on mute.
So sorry about that. So, and you've mentioned social determinants of health. We're going to talk about them, but this is a kind of one way of graphing what happens in terms of social determinants of health. Some of them are if you look at the orange areas, some of them are quite personal and individual. And then as you move out, you see that they are societal: education, living and working conditions, unemployment, water and sanitation. That becomes a cultural issue, a generalized issue. And of course, all of these create social determinants of health, lack of access. So we can't, unfortunately, we do a whole study on that. But what's very interesting is if you look at this chart, what makes people sick, 50% in this survey, 50% of what made people sick were very directly related to social determinants of health. And you'll notice that Aboriginal status is right up there with other inequities. And then it's your own health care, your access to healthcare systems, which, as you've mentioned, again, is very complex in the Indigenous area. And I can tell you it's very complex also for non-Indigenous people. And then we get down to genetics, and then we get down to air quality in your environment. So it's a very interesting analysis of what makes people sick. It's not a direct line the way people think. It has so much to do with social determinants of health. So the other issue that people are starting to understand better, and Carolyn, this again certainly doesn't only apply to Indigenous populations, but we do hear a lot about it in Indigenous populations, is the impact of trauma on individuals, and especially on their lack of access to social determinants of health. And the provision of services that respond to these specific needs need to be in a safe, culturally appropriate way. And those are the 6 principles that this group has identified as being important to giving trauma-informed care. So last slide, I think. Okay, so the summit talks about, I don't want to take any time with this because I like to give a few minutes to people to ask questions, but the importance of the summit as we've moved along through the years. You can go to the next slide. You can go to the next slide. So in the first few years of our summit, we talked about health policies as they are and how they affect us directly. And in the last number of years, we've talked about what do we think a good healthcare system should look like, which we call value-based healthcare, value to the populations, and the impact of social determinants of health. And so you've helped us very much understand when we get to our summit and we look at social determinants of health, we'll have a lot more information as a result of all that you've told us about those in the specific context of Indigenous people. So thank you so much for helping me today, and I know you're going to help us more at the summit. Are there any questions that people would like to ask in our last few minutes?
Just a reminder that if you have a question, please pop it into either the Q&A, I can see that, or into the chat. One question is, do you have any suggestions for possible, patient, caregiver groups, roles that they can be playing in terms of, it's complex, it's fragmented, getting from, development to people, any roles that patient groups can be playing in trying to help address the jurisdictional fragmentation, opportunities to work together, any advice?
Do you want to start, Carolyn, or would you like me to start?
Well, from my perspective, when I say First Nation, Inuit, and Métis, step number one is to know the difference between First Nation, Inuit, Métis, not the pan-Indigenous term. When we hear Indigenous people, when they hear Indigenous, it predominantly means First Nation. And then we get into know the difference between status, non-status, and you begin there. You begin with that. That's how you start, because safety and trust, if you're trying to establish a relationship with any underserved population, if you don't know the basics, you're not going to establish the trust. So if you're
that's our first steps as groups that have not worked in this area before, but want to work in this area, or at least help the leaders who are working in this area, the Indigenous leaders who are working in this area, to do their work. So we've got some homework to do, you're telling us, right?
That's just the beginning. I have a whole list.
well, you'll have a chance at the summit to tell us some more. And I would say, even certainly in the non-Indigenous work that we do, there is the processes are so complex and they're changing all the time, and it's really tough, I think, for individual patient groups to do service provision and even a group service provision, and also keep up on all of these changes. But I think that with the support of the individual patient groups, there are some who can really help them to craft the kind of advocacy and that we really need to do to change our healthcare system. And the pandemic certainly showed us, if we didn't know before, that they really need changes. So it's a kind of, I just believe in collaborations, in working together, in educating each other, and then each taking a part of the problem and taking a lead on that, and getting support where it's needed from other people in the population. So I don't know if that's us at time. Are there any other questions that anybody had?
Nothing that is coming through. We are almost at time. And one follow-up question: are there any coalitions or sort of established opportunities and platforms that you would recommend people, in terms of work collaborating and different groups perhaps helping each other be able to engage in this very complex landscape? Are there any that you would want to flag that people, if they're not aware of them, perhaps should become part of, to become more engaged in a collaborative approach to trying to address these complex realities?
Carolyn, or do you have a suggestion?
Well, it's you know, there's a lot of cultural safety training taking place. So wherever you are in Canada, you have to I mean, you could have a broad national type of knowledge, but there's also is important to know, you know, where your feet are on the land, to know the history of the peoples of where you are, right? Rather than this pan-Indigenous broad knowledge. So, you know, there's lots of Indigenous organizations throughout this country. So, you know, look to them. Look to them and see what they offer. Go on those websites and see who they recommend for cultural safe training. It all depends on what you want to know. Do you want to know a national perspective? Do you want to know a local, regional, provincial? It's a very complex history in Canada, but it's important to single in on, I think, of the differences and where you reside. You can't. That's how you form a trusting relationship, right?
Yeah, absolutely. Yeah, and I agree with you. You have to decide what, you know, where you want to sit. If you want to do something nationally, you look to national organizations. And we do have certainly in across the continuum, we have some amazing organizations. For instance, we have one called CanAge that does a lot of advocacy for seniors. We have some great mental health organizations doing fabulous work. I'd like to think that we're doing some education and support in the cancer field. So I would say start by finding out, you know, whether you want to be specific, and then to your point, do I want to know the national scene? Do I want to know the provincial scene? And where do I want to fit in? And then start your research for sure.
And make sure your research is from legitimate sources.
There you go. That's a good way to end.
Beware misinformation and disinformation. And thank you so much, Carolyn and Louise. Just want to remind people that registration is open. The summit begins next week. Visit patientsredefininghealthcare.ca to register. It is virtual, it is free. The first day will be really diving into the structural and social determinants of health and how do those impact people's health outcomes and access to health care. That whole piece of theory versus reality, as Louise mentioned. The second day, we will be diving into Indigenous health and issues there. And Carolyn, as along with other people on her team, are going to be sharing some incredible information about cancer care specifically, and people, Inuit residents from Nunavut accessing cancer care in Ottawa, as well as a lot of other really fantastic information coming through the second day on November 15th. The third day, we dive into solutions and we start to think about what are those foundational shifts that need to be happening to start to make this less of a fragmented mess for everybody, both on the patient and provider side. And then our final day for the patients and caregivers and patient groups that attend, the final day is open, and that's where we take the themes coming out of the first 3 days and we talk about what do we want to do about them, and we do a little bit of action planning together. So if you haven't registered yet, please do, and we hope to see you there. Thank you again, Carolyn and Louise. See all of you next Monday, and Carolyn, see you next Tuesday, or next Wednesday, sorry. We cannot wait. Have a wonderful rest of your day.
Thank you, Leah, for facilitating this for us.
Thank you, Leah.
Greatest of pleasure. It's an honor. Bye, everyone. Thank you again.